Okay, great. Thank you so much for joining us tonight for the Light Up the Beaches webinar event with Dr. Fuller. Just for participants joining the call, please note that at the end we will have a Q&A section, and the bottom panel of your screen you should see a Q&A icon. So if you open that and insert your question, Dr. Fuller will address those at the end of the session. Also, we are allowing participants to talk. So unless you've muted yourself, you also will be able to speak at the end during the Q&A section. And I'll turn it over to you, Keith.
All right, thank you, Holly. Appreciate everything you've done to help us get this set up for today. I also would just recommend if you keep your microphones muted during the presentation, because you can get echo and feedback if people have that on while you're talking, and only turn it on when you need to talk or want to talk. So thank you all for good evening and welcome to the Light Up the Beaches Purple event in recognition of International Overdose Awareness Day, which is today, and Recovery Awareness Month, which is September. This event is brought to you by the Twin Beach Opioid Abuse Awareness Coalition in collaboration with the Calvert County Health Department and Sneed's ACE Home Center. My name is Keith Pardick. I'm a council member here in Chesapeake Beach, and I chair the Twin Beach Opioid Abuse Awareness Coalition. And thank you so much for logging in and supporting our friends and families and neighbors who have been either directly or indirectly impacted by opioid use disorder, or for that matter, any substance use disorder. For those of you who have not heard of the Twin Beach Opioid Abuse Awareness Coalition before, it was formed in 2017 as a joint committee of the towns of Chesapeake Beach and North Beach to help raise awareness and educate residents about the opioid crisis, connect people in need with appropriate resources, help remove the stigma surrounding addiction, and ultimately save lives. The coalition is comprised of concerned town citizens and representatives of various county agencies and private organizations who are all committed to ending the devastating effects of opioid use disorder. The participating groups include the Calvert County Health Department, Calvert Alliance Against Substance Abuse, the Chase B. Mattingly for the Fight, also known as Positive Vibes, the Calvert County Public Schools, particularly Beach Elementary, Emmanuel Church Celebrate Recovery, the Circle of Angels Initiative, and the Calvert County Sheriff's Office. They are a great group of people to work with, and I want to thank them all for their hard work in pulling this event together. I also want to thank Mayor Mahoney and Mayor Benton and the town council members of the respective towns of Chesapeake Beach and North Beach for their support of the coalition over the past 4 years. We have a big night ahead of us. First, a 30-minute presentation by Dr. Drew Fuller entitled Community Engagement and Treatment Success for Opioid Addiction, Calvert County Leading the Way, and then there'll be a chance for questions. Then we'll close out this portion of the event and ask everyone to turn on their purple porch lights that we've distributed this past week. We've distributed about 300 in both Chesapeake Beach and North Beach. The town halls of both of our cities will be lit up purple as well. And after you light up your house purple, we ask that you share photos of it on our Facebook page. And I will show you, or I think on this, what I have screen sharing right now has some hashtags and a Facebook link where you can share those photos with everyone. So we'd really appreciate that. So, and I'll remind you of that at the end of the presentation as well. So without further delay, it is my distinct pleasure to introduce Dr. Drew Fuller. Dr. Fuller is the medical director of the Calvert County Behavioral Health Mobile Crisis Team and is board certified in addiction medicine and emergency medicine. He conducts a medication-assisted treatment clinic with a focus on opioid addiction. Dr. Fuller is a national patient safety leader and former chief safety officer for Altion Health that served 23 hospitals in Virginia, Maryland, West Virginia, and Washington, D.C. He has led the region he has led regional and national safety programs in opioid prescribing, as well as airway management and handoff communications, and has presented for the Robert Wood Johnson Foundation, the National Patient Safety Foundation, the American Society of Healthcare Risk Management, the American College of Emergency Physicians, and the Maryland Patient Safety Center. He has practiced emergency medicine for over 20 years and completed his residency training in both internal medicine and emergency medicine in the Johns Hopkins system. He received his master's in public health from Harvard University and his medical degree from the University of Florida. It's a great pleasure to have you here, Dr. Fuller. And now the webinar is yours. So please go right ahead.
Well, thank you, Keith. And I will see if I do this right and take the screen over.
Yeah, let me stop sharing here.
Thank you, Keith, Holly, Mayor Mahoney, and the town councils of Chesapeake Beach and North Beach. It truly is an honor to be able to present tonight. But I have to say, it's been an honor to be here in Calvert County for the last 10 years, 10 of those years in the emergency department at Calvert Health, and now within the last 2 years at the health department. And I've just been very fortunate to join this great team of leadership with Larry Polsky, Doris McDonald, Sarah Hanna, Denise Dickerson, and Jason Phelan that have been building an addiction response program for several years and is now not only leading the region, but leading the state and possibly even leading the country in what we're able to provide. So tonight, what I would like to do is share with you some of the insights that we have had and some of the insights that I've had, because I have to admit that I had to unlearn a lot of what I thought I knew about addiction in order to successfully engage this opioid epidemic. And we're going to share that with you. So it's a lot of slides, but I go quickly. But bottom line, I don't think this is going to surprise anybody, but this opioid epidemic is a tragedy and it affects everybody. It affects mothers and fathers and kids. Nobody is immune to the effects of this. And in fact, I think statistics have shown that 50% of people know somebody that have a serious addiction disorder. The problem with this addiction disorder is it's so incredibly fatal. And this is an old slide. You can see it ends in 2015, but it even goes up even higher, is that drug overdose deaths, and it's really opioid overdose deaths, are the leading cause of deaths in Americans under 50 now. And the numbers are much worse than we thought. And you will see, like, this is a stadium that has 72,000 people. Imagine the stadium of people dying, people in the prime of their lives dying every single year.
Interrupting.
Yes,
I don't see your slides.
Oh, really?
Yeah.
Go back. Let me try that screen share again then. Oh, I didn't hit the one button. Is that?
There we go.
Oh, there we go. Thank you, Keith.
Mm-hmm.
I'll just go through so if you imagine this football stadium is 72,000 people, it's probably even higher than this because, believe it or not, the deaths are underreported in a lot of communities throughout the US because of shame and stigma. And we're going to talk about that in a moment. And we're not immune from that here in Calvert County. And granted, this is an older slide, but Calvert County had the 10th highest death rate in the country a few years ago with opioid overdose of the 24 counties in Maryland. That's no longer the case, and we're going to go over that at the end. But it's only because of a lot of hard work from people like Keith and others that are advocating to get others into treatment. So we've said it's the leading cause of death in people under 50, and why is that? Well, that's because we're going to go through some of the science of it, but unfortunately, only about 1 in 5 people with opioid use disorder are actually getting proper treatment or medical treatment that actually has been shown to help. And there are a lot of reasons why that is, but probably the number one reason is stigma. And I think this is our number one greatest threat to progress and the opioid epidemic. And it's stigma not only against the disease, but it's stigma against the people with the disease. And it's even stigma against the treatments that work most effectively. And so let's talk about what I really mean by that. And stats are great, but stats will blind us because we get a little bit numb to them. And this is really a story not about statistics that will overwhelm us, but really about real people in our communities in both North Beach and Chesapeake Beach, but throughout our county and throughout Southern Maryland and throughout our country. And if you go to, I think it's Project Echo has a wall in it down in Prince Frederick, and then there's Serenity Acres just over the bridge. And you'll see these walls of family members that have died, that family members have put up pictures of their loved ones that have died. You'll see that these are actually real people, and they're young, and they're in their prime of their lives, and they're dead. And you know, it really brings home the reality of this situation. So this is from the Serenity Acres right here. And when I went and walked down that wall, I noticed a recurring theme, as you'll see on here, is that they're young people with kids are dying on a regular basis. And we'll see that we try to post it here in the county, but once again, we get pretty numb to these statistics. And so one overdose death, it used to be every 14 days, now it's every 29 days, but we still feel that that's too many deaths for us, especially when the people are averaging in their mid-30s. And so it's a lot of kids are dying with overdose, but a lot of people with kids are dying of overdose. And that's because the heroin is just so pure and so problematic, but we've now entered in what's called a fentanyl age, which is a synthetic opioid, which is so powerful that it's causing a lot of overdose deaths. And it's so not only powerful, but it's so profitable. So fentanyl is not going anywhere. It's being manufactured overseas in a lab. It can be sent in the US mail, and drug dealers can just make too much money off of it that they're now mixing it in with cocaine, they're mixing it in with marijuana, they're pressing it into pills and selling it as fake Xanax or fake hydrocodone. And so it's just everywhere. And we're even starting to see more synthetics being developed, unfortunately. So here's what I had to unlearn about addiction. I used to think addiction, having worked in Baltimore for so long and lived in Baltimore for so long, was a choice, and it was a behavioral disease. And the truth is, the more we study it, the more the scientists look at it, it's really a medical disease. And it's a medical disease that it affects the brain. And the secondary effects of that are a lot of behavioral components that we all hear about with criminal activity and other unhealthy activities. But once the brain really essentially gets hijacked from this very powerful chemical, we really have to have aggressive ways of treating it like a medical disorder. We can demonstrate that there's biochemical and even structural changes in the brain that happen once this addiction takes place. And so it's a medical disorder of the brain. We really need medical treatments to focus on what's going to affect it most effectively. Addiction, it's complicated, whether it's what led to the addiction, whether it was biological, sociological, social, whatever else it is, it's that brain switch. Once it happens, it happens. And these people, and this is one of the best metaphors I can come up with, is that it doesn't matter what drew the person to the edge of that water. Once they're in the water, they're in deep, they need help. And so here's what we tend to see in addiction cycles is people may start off using a substance because it makes them feel good and get some euphoria out of it, but they soon kind of come back down. And then they use again, and they get euphoria and they come back down. And so that may go on for months or years, but after a while, that euphoria phase really starts to fade out and people are just kind of feeling normal or they're withdrawing. And we're going to go over that in just a moment. So that's an important slide to keep in mind. So let's talk about lifestyle disease. So here's a lifestyle disease for you. 80% due to lifestyle choices, and that is diabetes type 2. 84% of diabetes type 2 is lifestyle related in males. It's about 80% in females. So I bring that up because I initially trained in internal medicine and then emergency medicine, and I used to treat things with the medical model that way, but I didn't understand addiction. But the more we look at it and the more the top experts look at it, is addiction is really no different than some of our other chronic medical disorders like hypertension or diabetes. The problem with this one is it's so fatal. And so here's some statistics to show that after someone has had an overdose, and if they survive the overdose, the death rate is upwards to 10% within the next 12 months. It's been as high as 15% within 30 days, depending on what people are using. And so people are dying from these overdoses, but not just dying from overdoses. There's other comorbid conditions such as suicide is happening because of drug addiction. HIV outbreaks are starting to increase. Hepatitis C is now on a wave that's going up, very expensive, but very treatable. $60,000 to $80,000 just to treat hepatitis C. And a lot of important things are happening. Death rates if people get admitted to the hospital and discharged without treatment. If people have opioid use disorder as a diagnosis and are incarcerated and then let out and aren't in treatment, the death rates are substantially higher than if those who are in treatment. Well, I keep talking about treatment. I keep saying that it's a medical disorder. Which treatments work best? So we had the old adage in the past that people should just quit, and that is possible, but it only works, they say, about 4% of the time. So yes, just spontaneous quitting works for a very small portion of people. Then we talk about rehab, and that was a model that so many of us had, and say, well, just send them off to rehab. It's expensive and it sounds great. They can go do very extensive therapies and they can reprogram their mind. And but the problem with rehab is if rehab is done by itself, and if it's less than 90 days, it's really closer to a 0% success rate within 12 months. And it has to be after not longer than 90 days, but even then you're looking at 5, maybe 10% success rates, very low. 12-step models, that's been the predominant model, AA, NA, they work great, work for multiple members of my family. I'm a huge fan, but done by itself works great, 10% of the population. So if I were out there as an emergency doctor giving someone an antibiotic that only worked 10% of the time for their pneumonia, I wouldn't be practicing very long. But that's what we've been doing in addiction medicine for so long. And then we blame the people with the addiction for the fact that it's failed. The families bankrupted themselves because they've sent a family member away for 3 or 4 times to get rehab. But by themselves in the old models at which we've done it, and thankfully things are changing, but rehab without medications is really a recipe for failure for the majority of people. So what does work? And that is opioid replacement therapy. And one of the examples I would talk about here is buprenorphine. This slide is a little bit not confusing, but it doesn't show the whole picture. You can see it goes to the top, but that top only says 70%. It doesn't say 100%. So still, buprenorphine is a medication that works great compared to everything else, but still doesn't work for 1 in 3 patients. So, but if we start doing buprenorphine and then combine it with a 12-step program or with rehab or counseling, then it's more likely to be a lot more effective. So really, it's about a comprehensive approach. The reason I keep saying we need medications is that so many people think, well, you can't do medications. You're just replacing one thing with another. And the reality is, we'll talk about why that's not the case. But medication therapy alone is not really good enough. People need a lot of support. They need interventions to help in a comprehensive way. So what are we aiming to do by having opioid replacement therapy or opioid agonist therapy? Is that we want to get them out of that cycle of withdrawal and trying to get normal again and to keep them in a more plateaued state. And it's shown that like psychotherapy helps with some forms of addiction or like counseling and everything else, but it works in certain parts of the brain. Medication works in other parts of the brain. This is just a slide that's showing you, I send them the detox and they can come off. Well, the fact is detox doesn't work because they're just going to relapse. This is a slide trying to compare buprenorphine versus counseling. And my wife's a counselor, so I'm a big fan of counseling. And we have great counselors here. But counseling alone is not the treatment for opioid use disorder. But combined with medications, they can do very well. So it's access to medications is what people really need. And we need to break through the stigma which people that try to dissuade their loved ones from getting on medications or institutions that weren't providing them. And so we're making a lot of progress in that. So buprenorphine, what is it? It's a medication. I'll take a step back. People have probably heard about methadone. Methadone's been around since the 60s. It works really well, but a lot of people don't want to be on methadone because they have to go every day to get a dose, or they may not like the way methadone makes them feel. Buprenorphine is a medication that people don't have to go every day. It's a prescription. It's very safe. What does it do? It basically goes in and binds those opioid receptors and kicks off heroin, methadone, and everything else, and it binds 1,000 times stronger and sticks around for about a day and a half, so about 36 hours. The thing about buprenorphine is it doesn't stimulate that receptor as strongly. And that's part of the downside of it, is because it can cause withdrawal if people are actively using one of these medications. But the upside of it is it's very well tolerated and very safe. People can double, triple, quadruple their normal daily dose, and they're not going to overdose. They can be sitting here giving you this presentation right now. I have patients that operate high-powered linemen, multiple 1,000-volt lines, and work very safely on it. One of my patients is number 3 in the world in 3-dimensional archery, a very safe medication. In fact, if I had a room full of 20 patients, you wouldn't be able to tell that probably hardly that any of them were actually on a medication. The number one thing I hear my patients say time and time again is, I feel normal again. That's what they say to me. Once we get them on medication, once we get them the support, and then they start to rebuild their lives, the number one thing is, I feel normal again. So if we look at societies that, in communities that they've started using buprenorphine, and they're able to decrease the death rate by 80% with buprenorphine alone, and that's in communities that actually had methadone treatment already in place. So how does this compare to what I used to do as a physician in primary care and emergency medicine? If we looked at relative effectiveness for preventing bad outcome, I'll just go over one or two of these. If people on blood pressure medicine, if you've never had a heart attack or a stroke, and you take blood pressure medicine for 5 years to prevent death, heart attack, or stroke, there's about a 1% chance it's actually going to prevent that within the first 5 years. It gets better over time, but that's really where it is. If someone has had a stroke, is on a cholesterol agent, there's about a 4% chance it's going to prevent another event within the next 5 years. But if you're on it for 30 years, you got to add all that up. It's going to make a difference. And if you're part of that percentage that it makes a difference, hey, that's a big percentage. But I do show you this slide to show you how effective buprenorphine can be for preventing bad outcomes like death for people who actually take it. So compared to what I used to do, I actually feel that I can save a lot more lives and help a lot more people doing addiction medicine than what I was doing as an emergency medicine doctor. This is just an example of the patients when they're stable. They're very proud of it. And this is a patient who actually tracks his number of stability days on his app and says he hasn't had a craving in 497 days since starting medication. Lots of benefits. People get reemployed. They get re-engaged with their families and their communities. I have patients that are showing me the cars that they're buying, telling me about the houses that they're now qualifying to buy. There's 80% decrease in mortality, which we talked about. There's an 80% decrease in crime. And if the people are on the right dose with the right support, 70–80% can do very well on this medication. Wish it was 100%, but we're just not there yet. And quite frankly, some people who enter into treatment, even with good medications, aren't necessarily ready. And so just what's really important to help get to these myths and misunderstandings is to, and that leads to stigma, is to show that they're not trading one drug for another. They're trading a life of a 24/7 obsession and chaos and danger with a medication they take once or twice a day, and they can continue on with their lives and feel normal again. Some people say, well, they're just taking the buprenorphine to get high, and that's really not the case. Most people that are diverting buprenorphine are using it from the streets to help prevent withdrawal. It's not a great drug of abuse. It will actually cause withdrawal if people don't time it well, and then it actually will prevent people from getting high for 36 hours because it sticks around for too long. So what we used to think about it really didn't apply. It's such a powerful medication, and unfortunately it hasn't been available in the jails yet, but it's going to be there soon. But it's starting to be accepted by our drug courts and other institutions, and our jails will be providing this therapy within the next 3 years. I wish it was this year, but it's not necessarily the case. But the National Academy of Medicine had to come out with a report saying this is so impactful and so important. To not provide this at every level of medical care is really unethical. The beauty is we now have it at the hospital. If someone goes to the emergency department, they can get a dose of buprenorphine, and it hasn't turned the hospital into a drug treatment program. It's actually helped people get reconnected, and they're twice as likely, if they get a dose of medication in the ER, twice as likely to follow through and follow up for outpatient care. And they're 50% less likely to return to the emergency department seeking opioid treatment. So treatment works, supported by all these organizations, the NIH and the CDC, and the American Medical Association and the White House, and all these medications here show that buprenorphine, or what we call medically assisted therapy, and we got to stop calling it medically assisted therapy. It is the therapy, and everything else is the assisted part. It's supported by all these organizations. So it's not a new standard of care, it is the standard of care. Unfortunately, when I told you that only 1 in 5 people are in treatment, it actually may be as low as 1 in 10 in some segments of the country. Not that way in Calvert County, and we'll talk about that in a moment. We talked about this. I want to share with you, just to check the time here, how proud I am and how lucky we are in Calvert County to have the services that we have. And before I go into what the mobile crisis team does, we've had a recovery rapid response program that's been building over the years. Instead of waiting a week or two to get someone into treatment, it got it down to a couple days. Well, now it's really treatment on demand. So we have offices that are open in Prince Frederick in our main health department office, open 7 a.m. to 11 p.m. 7 days a week. That is absolutely unheard of in the addiction world. People can literally stop by our office 10:30 at night on Christmas Eve, and they're going to get plugged into treatment. And so to be able to get that is really unheard of. Well, what if people can't make it to us? So we do house calls. I like to say we'll put a doctor on the doorstep, but it's not just a doctor, it's a whole team of people. It's a nurse practitioner if the doctor's not on, but it also includes a peer recovery specialist. It includes a licensed counselor, and we'll go into people's houses and we'll engage them and we'll assess them and we'll make a recommendation on treatment options for them. And so it's amazing that Calvert County has this. Here's an example of this van. It's a 2-room clinic, and we can see someone in this van just like it is a clinic. And we'll go out into the woods and see people. We'll go into basements and see people if it's safe. If somebody overdoses and the paramedics and the police arrive and the police have made sure the scene is safe and the paramedics have made sure the patient is safe, and if the patient is medically stable and they want to, they can come to us and we'll start treatment with a 3-person team immediately dedicated just to them. If they're unstable or they want to go to the ER, well, great. And then the ER is going to take great care of them as well and refer them right back to us. So we're really lucky in Calvert County to have these services. Unfortunately, we're one of the best kept secrets out there. And so we're trying to get the word out on why it really matters. And we're doing it through a collaboration. And that's what we really want to talk about here tonight, is collaborating with community members and businesses to help get that word out. So we're working with EMS and law enforcement, and they know what we're doing and they're collaborating with us and they're calling us. We have a billboard that's out there, kind of direct to consumer advertising. I wish I had a picture of that billboard from Dunkirk, that anybody in the community can call the 877 number. The hospital is now putting it on all the discharge instructions from any patient that comes to the ER. A little line on the bottom will talk about that 877 number for the health department to get addiction and mental health care. And it's screened by mental health professionals. So you get a live person almost immediately. And for the most part, you do get them immediately. We're working with the hospital, as I just mentioned, working with other community organizations. The town council and the mayor and Keith and Holly have been really instrumental in trying to move things out into the community of North Beach and Chesapeake Beach, so we can get greater awareness and help break down these myths and misunderstandings and even break through that stigma against the disease and against these treatments. And so we want people to have a very low threshold for calling that 877 number 7 days a week. And here's something that's kind of apropos for the time. So this opioid crisis is getting worse during this COVID pandemic. And nationally, we're seeing opioid overdoses where we were making progress, we're now losing ground. And the overdose deaths are now going up. And Maryland is not immune to that. So Maryland has had a 7% increase in overdose deaths. And if you can look on this chart here, but I don't know how well you can see that, but this is from the OOCC, which is the Opioid Task Force, the Opioid Overdose Task Force in Maryland. And it shows that 21 out of the 23 counties have had an increase in overdose deaths within the last year, except for 3. And Calvert is one of them. So we've had a 30% decrease in overdose deaths. Granted, the caveat here is it's a relatively small number now, so there could be statistical variation and we could be up next year. But when everybody else is going up and we're going down, I'll take it, and let's keep this ball going and let's start running with it. And several of the things we're doing is people can put bumper stickers on their car with this 877 number. We have window clings that businesses can put up. We have business cards that people can give out, and a lot of my patients are giving out. I know Keith and Holly and the mayor and others were in favor of, they put it out in water bills in the community, and that's just been unheard of. It's been done in other communities, so that's just amazing. We're looking for ways for business partners and others who want to team up with us and help get the word out. And we know it's not all about just getting someone on a medication. It's a comprehensive approach. It's about prevention. It's about treatment, and it's about harm reduction if we're really going to make progress with this disease. And so I will end with a metaphor, if I may. What's the better option for people? Someone in opioid addiction, this is what their life is really like. And once again, I have patients, it's a 24/7 obsession, and they can spend, I had a patient just admitted he probably spent about $200,000 in the last 2 years on opioids, and his wife doesn't know. What's better, a 24-hour obsession with near death, or getting in therapy and getting in recovery? And so you can see the guy in the kayak, he's not out of the woods. There's still lots of hazards there, but that person is now far more empowered to steer their destiny and their life. And with the right team and the right efforts, those people can be guided through these hazards so that one day they truly can meet their destiny with their family and their loved ones. And so as an ER doctor, I used to love to save lives. We took a lot of pride in that in my ER team, but we can really save generations if we can treat people and get them into treatment. So it's not about numbers, it's about people. And I think Lisa and Joseph and Trevor deserve them. And so at this point, that is my presentation, and I would like to open this up for questions. And
yeah, that would be great. Thank you, Dr. Fuller. That's a great presentation. And if folks have a question, they can either unmute themselves and ask it, or they can type it into the chat line, or I guess there's a Q&A function as well, if you click on that. So we'll give folks a minute or two here to see if there are any questions pop up. And while we do that, I'm going to go ahead, if I can figure it out, share that screen again with information.
Oh, you want to put my slide back up, or no?
I'm sorry, what's that?
Oh, I didn't know if you wanted me to put my slide back up.
You certainly may. I have to unshare this. I just wanted real quickly, before you do that, there is this, when we leave here, what I'd like folks to do, if you haven't already done it, is turn on your purple lights. We gave out about 300 of them across the town. And be sure and take a picture and share it with us by either on Facebook or via these hashtags here. These are local. The Twin Beach Awareness is local, and hashtag Overdose Aware Calvert is local, and the other two are national or international hashtags, where you can share photos of your purple lights shining, or if you see displays throughout town, North Beach or Chesapeake Beach, and you want to capture a quick picture and post it, that would be great. So I'm going to stop sharing that at this point. And if you would like to share that slide again, you may.
Oh, okay.
And so it doesn't look like we have any questions at this point. And hopefully y'all can get this information down if you need it. I believe this presentation has been recorded and will be on the Chesapeake Beach website. So if you know people who wanted to come, and I know a couple who wanted to, but they couldn't, definitely let them know that it's going to be up there, and we'll also send something out. And we do have a question. At Emmanuel Church, Celebrate Recovery, we recognize the need and beneficial use of MAT, but we have been concerned about the time individuals are on it. We see periods of 4 and 5 years in some. What is the criteria for determining the period of time spent on it?
So it turns out there really is no time limit. So it has to be based on what the patient needs. Unfortunately, I've seen some catastrophic outcomes from people that were pressured to get off their medications. And I used to ask myself that same question, Jane. I used to think, well, why are they on this for so long, or what are they going to do with their lives? And the reality is I had to start asking myself that question. Like, I don't ask my diabetics why they're on their metformin, and yet 80% of my patients could probably not be on that medication with lifestyle change. So I have to tell my patients, number one, they're in the driver's seat here, and we have to support them through it. So the science is actually showing that they can be on this medication for years. They can be on it for a lifetime if they need it. Now, I will say this, most people, almost everyone, do not want to be on this for a lifetime. It's not easy. You have to come see me. You have to get an evaluation. You have to give a urine. Sometimes there are people witnessing the urine. Then you have to go to the pharmacy, and maybe the pharmacy doesn't have your medicine. Are you going to withdraw? You're going to feel terrible. Then you have to call over and have to go to another pharmacy. And so there's really a lot of steps that people have to do to stay in recovery on medications. And so most people, if when they're ready, they want to start coming off the medications. But the top addiction scientists in the country say there is no time limit, and we probably have to reframe our thinking behind that.
All right, thank you very much. All right, I don't see any more questions. So with that, Dr. Fuller, thank you very much for being here tonight and sharing all that information, the great work you guys are doing. And it's really great to see how the numbers are going down, but we do have to be vigilant, like you were saying, and especially now during COVID, where the numbers seem to be rising again. This is our first event. We were kind of doing them pretty regularly until COVID hit. And so we are really happy to become active again. And thank you for participating in our first event.
Well, great. It's been an honor. Thank you for having me.
All right.
Thank you, Dr. Fuller.
So with that, I'd just like to thank all the participants for coming out and participating in or listening to Dr. Fuller's presentation. Remember to turn on your purple lights and take those pictures and share them with us. And I'm sure we're going, Holly, correct me if I'm wrong, but we're going to share probably another email blast with this, letting people know where they can find this presentation. Is that correct?
Yes, absolutely.
Okay, wonderful. Well, thank you again, and y'all have a great evening.
Thank you. Good night.
All right, night.
Night.